let's talk about heart failure and talk about some emergencies. So we've already talked about what causes symptoms. I'm going to now move on and briefly cover the impact of heart failure on the NHS. Why should you care about this heart failure condition? Not just because I care about it. I'll talk about the different types of heart failure and then cover medications. And then we'll go through an emergency case, such as you might see on CDU, and how you should manage it. So what does everybody think the impact of heart failure is on the NHS? So can anybody tell me how many bed days heart failure is responsible for a year in the NHS in England and Wales? Does anybody want to hazard a guess? So the answer. Very good, Emmanuel. Nice to see you again. So 1 million inpatient bed days. So that's very good. That's a huge number of bed days for one condition. And that's both because heart failure patients tend to get admitted a lot and they tend to stay in hospital for a long time. We have about 2,000 heart failure admissions in Leicestershire, so colossal number of patients coming through the door. What proportion of emergency medical admissions to hospital does heart failure represent? So of all medical emergency admissions to hospital, heart failure accounts for 5% of admissions. So it's a very common cause of medical admission, and it's often a comorbidity. Or it's part of often patients come in with a chest infection, but also have heart failure as a cause of their chest infection. And what about their risk of readmission or death within 60 days? Anybody want to hazard a guess at how likely a patient is to end up back in hospital again within 60 days? So the answer to that is 30 to 50% risk, and different series show different things. And this is really important number because this is a patient who's done very, very badly. And if you really carefully manage patients, you can reduce this figure. Part of it is careful management in hospital, part of it is careful follow-up post-discharge. But the outcomes for patients with heart failure remain very poor. This is a recent registry, and this is looking at the difference in mortality between NYHA class 4 at presentation to NYHA class 3. And you can see that there's a big difference in mortality, and this is despite optimal treatment of these patients. These patients do badly. And if we do a good job of looking after them, we give them the best chance of doing well. So think about that next time you send somebody home with heart failure. That have they properly stabilized? Are your follow-up plans right to stop them from ending up being this statistic? We know that patients with heart failure, we do a national audit every year, we know that as you get older, you do less well. That's not surprising, is it? I think you could say the same for most conditions. But what we also know is patients with heart failure do much better under cardiology than they do under general medical care. And they do much better if they have specialist input versus no specialist input. So, it reiterates what I've just been saying about how managing these patients well is very important. Let's talk now about the types of heart failure. Can anybody tell me the different types of heart failure? So what different types of heart failure do you know? Come on, put something in the chat. Is it too obvious? Yeah, right, heart failure, that's one way of looking at it, but I would say that's more symptoms. So left heart failure can be with or without preserved ejection fraction. Good, that's better. Thank you, Emmanuel. So you can have left ventricular systolic dysfunction, or you can have heart failure due to problems with the left ventricle, but it's not weak. And that's the one that really confuses people. And I will talk about that in a minute. And you can have right heart failure. We don't tend to describe diastolic right heart failure. We just talk about the right ventricle as being impaired and dilated or normal size and normal function. Good. Any other causes of heart failure? So you could a structural problem with the heart. So you could have a hole in the heart, blood going through between chambers where it shouldn't, or you could have a valve problem. So severe aortic stenosis. You could also have high output cardiac failure or constrictive pericarditis, so problems with the lining of the heart. So there are other things, but the main ones that you should be aware of are the left ventricular systolic dysfunction, heart failure with a preserved ejection fraction, the valvular and structural problems. Right heart failure is almost always secondary to a problem on the left side. So there are rare cases of primary right heart failure, and that could be caused by example by a big pulmonary embolism, or very rarely by something called pulmonary arterial hypertension, which is a very rare condition. It can rarely be caused by a right ventricular infarct, but it's much more commonly due to a problem on the left side. And don't worry too much about constrictive pericarditis. So what do I mean by left ventricular systolic dysfunction? I mean that the left ventricle isn't pumping well. I mean that this is weaker than normal, and as this squeezes, it squeezes out a smaller proportion, a smaller ejection fraction, a smaller proportion of its volume with each beat. So what happens if the left ventricle is struggling? What happens to the heart? What do you see on an echocardiogram? So if the left ventricle is not pumping very much each time, one way of pumping a little bit more is to get bigger. Because if you've got twice the volume, pumping a quarter of twice the volume is more than pumping a quarter of half the volume. So if it gets bigger, even if it's not squeezing very much, it's still getting more blood around the body. And so one of the ways the heart compensates for being weaker than it should be is by the left ventricle dilating. And that is a bad thing. So if you see mild left ventricular systolic dysfunction but severely dilated left ventricle, that's a bit of an odd echo report, but the severely dilated left ventricle should make you very concerned about the patient. So dilation of the left ventricle is a bad thing. That shows that the patient's heart failure is not well compensated, that they're further on with the disease progression. So look for left ventricular systolic dysfunction and look for dilation of the left ventricle. Now, if the heart's finding it hard to push the blood out, that's going to mean that the pressures going in end up going up because it's harder to get blood out of the heart, so it's harder to get blood in the heart because everything is backed up. So the left atrium will often dilate in somebody with poorly controlled heart failure, with heart failure that has been progressing over time. So for a long period of time, your ventricle's been failing and dilating. And then your left atrium will dilate. And that can indicate symptoms. So if you have a young person with severe LV impairment and no symptoms, it's highly likely that their left ventricles are normal size and their left atriums are normal size. It's much more common to be getting severe symptoms when you're having the dilation of the chambers. Now, the pressures have gone up in the ventricle and the atrium because it's hard getting blood through the left side of the heart. What happens next? It becomes harder to get blood through the lungs. So the right side of the heart has to work harder. And the pressures go up on the right side of the heart, so the right side tends to dilate. So very often when you look at an echocardiogram, if you've got a left-sided problem with the heart, it will also cause secondary problems on the right side. So expect secondary right ventricular failure. So when you've got a patient in their 80s who has right ventricular failure, it's pretty unlikely to be primarily a cause that you can deal with. So it's possible they've got pulmonary embolism and thromboembolic disease causing pulmonary hypertension. It's certainly possible, need to consider it, but it's much more likely that this is all secondary to problems on the left side. As the ventricle gets bigger, you very often start to see a leak in the mitral valve. And that's because if you think of the mitral valve as a fairly thin, floppy structure that's hinged on the walls of the atrium, with some strings called chordae attaching it to the papillary muscles, which are surprisingly chunky things that you don't realize until you start scanning hearts how chunky papillary muscles are. And these contract to close the mitral valve. Now, if your ventricle dilates, that stretches the mitral valve. And the chordae don't stretch, they're stiff, they're not supposed to stretch. So they often don't meet, the valve doesn't therefore meet properly in the middle. And so you get a central jet of mitral regurgitation secondary to the dilation of either the ventricle or the left atrium. So you often get secondary mitral regurgitation, and that goes straight through the middle of the valve that's not closing properly. So it's functional mitral regurgitation. So that's something you often see. And when we see that, it's not likely that the mitral regurgitation is causing the problem with the heart being weak. It's likely the weakness of the heart is causing the problems with the mitral valve. Patients with heart failure do badly over time. They are constantly deteriorating. And I get frustrated when I see patients who it says in the notes or the clinic letter, patient stable. They're not stable, they're dying. And it's incumbent on you when you see them to try and stop that. It's trying to help them, try and make them live longer and be better for longer. Just because they don't have symptoms now doesn't mean that they are not declining. And along the way, often patients have decompensations. And when they have a decompensation, they don't usually get back to where they were before. And often their decline can start to accelerate. But this can mean that a patient might think their numbers up during this decline and you manage to salvage them. And then they think their numbers up again. And yet you manage to salvage them again. And by the time they get to this point, they can be thinking, the doctors have got this sus, they'll sort me out again. So they might actually not realize that they've done very well to get as far as this, and they're very fortunate that good medical care has got them this far. They might think that they could carry on and they could be on a very different page from you when you start to have conversations about their future. So bear in mind, it's not like cancer. Cancer, unless there's a new additional treatment that patient can be offered, nothing is 100%, but you know that the patient is going to decline. Heart failure, they can look terrible when they present decompensated, and then they can live fairly symptomatically well for years afterwards. And they can always remember the doctor said they weren't going to survive and never believe you when they say that they're not going to get through this episode now, this time. So that's how patients tend to proceed. And that is so important to stop patients from deteriorating. Now, if you have left ventricular systolic dysfunction, do you know of any treatments for that? Can you suggest me any treatments for patients with heart failure and left ventricular systolic dysfunction? Anybody want to type in Yeah, so in the chronic setting, what are the long-term medications where you've got heart failure with reduced ejection fraction, where you have, say, you've got moderate to severe left ventricular systolic dysfunction or an ejection fraction less than 35%? So nobody wants to volunteer anything. Ah, excellent. Thank you. So beta blockers, ACE inhibitors, ARBs, angiotensin receptor blockers, and diuretics. Yep, very, very good. So lots of treatment options there, and spironolactone, good. So all of those I would agree with, and I would be keen to get patients onto all of those medications if their renal function allows. That, and if they, sometimes patients are very symptomatic with postural hypotension, and that can hold you back. But blood pressure itself isn't a reason not to try and help the patients, because sometimes if you treat their heart failure, their blood pressure gets better. This is a trial called Solved. This is one of the early trials of ACE inhibitors. So this is enalapril versus a placebo. Back then, we tucked patients up in bed, gave them some furosemide, and there wasn't a lot else you could do. So this was a time when patients didn't have all the treatments we have now. And you can see that within 3 months, the risk of mortality had been decreased by 50% in patients who got the enalapril versus who were on the placebo. So when you see your really poorly patient with heart failure in hospital and you think you might send them home for the GP to start the ACE inhibitor because you're worried about something stopping you, then just think how much harder it might be for the GP to start the ACE inhibitor and not able to do close monitoring the way you can in hospital, and think, I could reduce their mortality by 50% by starting this drug. That is quite something, isn't it? I would say this is probably shows the top end of the benefits of an ACE inhibitor. We would say it's probably around a 30% reduction in mortality. But how much do you do that reduces mortality by so much? And look how rapidly these lines separate. Within a month, there is a marked difference here. So this isn't a case of, let's send them home, let's, up titrate this medication over the next year or so. This is if you can get it started and get it going at a decent level fairly rapidly, then you can make a huge difference to how the patient does. We know that if you don't take a beta blocker and an ACE inhibitor, your prognosis is poor. We know if you take both, your prognosis is much better. Beta blockers have a similar reduction in mortality. Spironolactone was mentioned. So this is a mineralocorticoid receptor antagonist, and that reduces mortality by maybe 20%. So another considerable benefit from a simple medication. We could also think about defibrillators for patients with left ventricular systolic impairment. These are more effective because the risk is higher in patients with a history of ischemic heart disease. But the defibrillator will reduce mortality by about 30%. And if they've got left bundle branch block, they can have cardiac resynchronization therapy, which again has a very considerable reduction in serious adverse outcome events. So this is a composite rather than just mortality this time, but it still has a very good improvements in mortality and hospitalization. And this is where patients have left bundle branch block. So some really good treatments that you really all should be aware of. There are lots of other things besides, and I'll come on to one or two of the other things in a minute. Digoxin has been mentioned. That has some limited benefits. I would use it in somebody with atrial fibrillation. So modest benefit from the DIG study. So let's then talk about heart failure with a preserved ejection fraction. So what do you expect to see on an echocardiogram in a patient with heart failure with a preserved ejection fraction? So diastolic dysfunction, their echoes are often report grade 1, grade 2, grade 3, grade 4 diastolic dysfunction, and it's based on looking at the flow across the mitral valve. And actually, it's not worth looking at. It's just one of those historic things that every echo person gets taught to report, but actually the value of it is extremely limited. Because most elderly patients will at least have grade 1 or grade 2 diastolic dysfunction, and then it can become pseudo-normal before you get to grade 3. Maybe if you've got grade 4 diastolic dysfunction, that's of some merit, but by then you've probably gone into atrial fibrillation and you can't see it anyway. So diastolic dysfunction as a description on an echocardiogram is not very helpful by and large. If you had a 20-year-old patient and it said grade 2 diastolic dysfunction, that might get me excited, but the vast majority of our elderly patients is not of any value. And so what else might you look for on an echocardiogram? Well, I often get answers a valve problem, and heart failure with a preserved ejection fraction specifically is a problem with the way the muscle is working. It's not a structural problem. It's not a valve problem. This is a problem with the way the muscle is working. Now, it's actually really quite complicated. It's very hard to see a muscle relax. It's very easy to see how hard it squeezes. It's very, very much harder to see how well it relaxes. Um, and so we don't call it diastolic heart failure, partly because we can't really show that it's diastolic heart failure. Um, and actually, some of the early features of heart failure with a preserved ejection fraction are actually the muscle is not contracting quite as well. So it's really clinically or sort of scientifically is not diastolic heart failure. But if you, as a non-specialist, want to think of it as a stiff heart, as a diastolic heart failure, that will get you basically everywhere you need to go. So I think as a crutch, it's not a bad crutch. It's not quite true, but if you want to think of this as a stiff heart, then that's absolutely fine by me. So if you have heart failure with a preserved ejection fraction, it tends to be caused by getting older, being overweight, being unfit, having high blood pressure, and you often get thickening of the heart muscle, left ventricular hypertrophy. You don't have to have this, you often get it. So that would point towards heart failure with a preserved ejection fraction. Note the chamber size remains the normal size. It's the muscle that gets thicker. And if it's harder to get blood through the left ventricle, you get exactly the same thing as before. You get raised pressure trying to push the blood into the left ventricle. And so the major hallmark of heart failure with a preserved ejection fraction that you need to make the diagnosis is a dilated left atrium. To make the diagnosis, you need a dilated left atrium, symptoms, and an NT-proBNP is raised, telling you that the symptoms are due to the heart failure. And obviously there are other reasons why an NT-proBNP can go up. And if you've got a frail elderly person, you're not sure if it's incidental finding, and that actually there are other things that are the limiting factor, as we talked about all the different causes of breathlessness before. But you need those three things. So left ventricular hypertrophy is an option, may or may not be present. What you need is a dilated left atrium telling you that the filling pressures are high, getting blood into the left ventricle, symptoms and a raised NT-proBNP. Now, having got the high pressures going into the left atrium, the pressures are high coming out of the lungs, so you get secondary right ventricular failure. So you very often end up with a patient with an echocardiogram showing a preserved LV systolic function, a dilated atria, and severe right ventricular dilation and impairment. And that can be entirely secondary to the problem on the left side, and very often is. So that is a common finding on the echo, and the problem is not primarily the right ventricle. Don't consider it, it could be, but it's much more likely to be secondary to a problem on the left. This is an example of somebody who obviously lived with a very thickened, stiff left ventricle for many years. And this is obviously a cross section through it. This is the heart is a cylinder shape. The left ventricle is a cylinder shape. You can imagine this is a cross section through it in the short axis. You can imagine how stiff this is and how difficult it is to make this expand, and why that might cause symptoms of breathlessness. Also, the heart's blood supply comes from the outside, and the ability to perfuse the heart muscle is the balance between the pressure going in, the distance it's got to travel, and the pressure inside the heart. If the pressure inside the heart is high, it's going to be hard to push blood through the blood vessels. So you can imagine how hard it is to get blood to the inner bits of this bit of heart muscle. And so that often causes ischemia, and your patients have a chronically elevated troponin and get chest pains. So chest pains are a common feature of cardiomyopathies, particularly hypertrophic cardiomyopathy. What do we mean when we say left ventricular systolic impairment? People get confused between me saying severe left ventricular systolic impairment and then they read a textbook which says less than 30%. Well, the terms are interchangeable. You can use a description or a number, whichever you prefer. So normal, we say, is over 50%. Actually, that's a very hard thing to say. What really is normal, particularly in a young person where their heart function might not look that good. But actually, if you got them to exercise, suddenly their heart would start working, and you'd see it working much more vigorously. So it's hard to say what normal is, but we tend to say over 50%. But we might need to give a different parameter for women versus men. For now, I think it's easy for you just to remember over 50% is about right. Over 60%, we're very happy, but over 50% is probably normal. And what does it mean? So in terms of the diagnosis, we talk about left ventricular systolic dysfunction, less than 40%. We call that heart failure with a reduced ejection fraction. I apologize for the terms, I didn't make them up. Or HEF-REF, using the little r to indicate the reduced. Try not to make it look too much like a P. And these patients are the patients with left ventricular systolic dysfunction that we can do so much for, as I was telling you about a minute ago. Ejection fraction 40 to 50% is heart failure with a mid-range ejection fraction. The name has changed recently. And I think it's actually might have changed to mildly reduced ejection fraction. This is an area that we are not so sure about what the best treatment for it is. Probably everything you give for reduced ejection fraction works, but not quite as well in this cohort of patients. But the evidence is lacking. So you might want specialist input. I would tend to give these patients an ACE inhibitor and a beta blocker, and if they're symptomatic, mineralocorticoid receptor antagonists with spironolactone. But you may want to seek advice about this cohort of patients. And if they're not symptomatic, I wouldn't add in the spironolactone. And then you have heart failure with a preserved ejection fraction, with ejection fraction over 50%. And this has an enormous impact. It doesn't have any impact on prognosis. You can die of heart failure with a preserved ejection fraction. You can die of heart failure with a reduced ejection fraction. It really comes down to how severe the symptoms and raised the BNP is and comorbidities as to the prognosis. So ejection fraction doesn't tell you how well the patient's going to do. But it does have a massive impact on how you treat the patient. So if you've got a reduced ejection fraction, there are lots of fantastic, really beneficial medications that we can start patients on. And we haven't yet mentioned sacubitril valsartan or an SGLT2 inhibitor, these diabetes drugs like dapagliflozin, 10 milligrams once a day, that are very beneficial for this cohort of patients, and other things besides. If you have the mid-range ejection fraction, as I've said, there may be some benefit to these, but we're less certain about it. If you've preserved ejection fraction, actually the evidence base for treatment is very much more limited. Probably there is a role for spironolactone. There is a limited role for SGLT2 inhibitors, although NICE hasn't ruled on that yet, and it actually only really had a limited impact on these patients. So it's so important to know the ejection fraction because it will have such a massive impact on what you can do to make that patient live longer. And knowing the cause of the heart failure is actually much less important than knowing the ejection fraction because, okay, if they've been poisoning themselves with alcohol or cocaine or anabolic steroids, then stopping that harmful activity may make their ventricle recover. So that's important. But if they've got something like ischemic heart disease, there's actually relatively limited benefit to revascularizing patients, which I'll talk about more another time. So if there's a reversible cause, for sure, we might want to know about it. But otherwise, it's most important to know that you're getting the patient on the right treatment. And a very big and important part of managing the patient well is getting them to exercise. So for all types of heart failure, it's beneficial to do rehabilitation and to have a healthy lifestyle and get the community heart failure nurses involved. Although the evidence base is much stronger if you've got a reduced ejection fraction. So that's a bit about how heart failure in general, how you manage heart failure. Now let's have a case. So imagine that you are seeing a patient you care deeply about. He's very important that you look after him well because he's only 35-year old and he's married with 3 children. He reminds me very much of myself. So imagine you're on the admissions unit and this gentleman comes in and he's complaining of generally feeling unwell for the last couple of weeks and then suddenly getting really short of breath. He's not got any peripheral edema. He's not got any past medical history of note, and he doesn't take any medications. He's apyrexial, but he's tachycardic and hypertensive, and you examine his chest, and he's got profuse bilateral crepitations. I'm sure you want a chest X-ray. You can have a chest X-ray. So I could ask you to tell me what that shows, but I think you probably all agree that that looks like fairly florid pulmonary edema. So are you thinking? Thank you, Hussein. Very good. You obviously typed that before I had said it. Very good. So what are your thoughts about this patient? What are you going to do for him? We give you some options. You can either give him IV fusimide, or you can give him IV fusimide and nitrates, or IV fusimide, nitrates and opiates, or you can give him fusimide and non-invasive ventilation. What do you think we should do for him? Does anybody want to bump for A, B, C, or D? So somebody wants to give IV fusimide. Excellent. Yes. Any advance on that? A. Yeah. Anybody else? Everyone happy giving him just IV fusimide? So I hope what you're all thinking is that you don't really know what to give him because I haven't really given you enough information, have I? Because this chap is obviously pretty poorly. And if Well, yes, you've not had the full history, but you probably need to get treating him before you get the full details of the labs and everything else back. But absolutely, we need the more information. But here it's his respiratory rate and how tired he's looking that is the more critical thing, because if he's um, if he's got exhaustion and if his CO2 is starting to rise, if he's hypoxic, then that would be a sign that maybe we need to move more rapidly to frusemide and non-invasive ventilation, because that will help to push the fluid out of the wrong space and will help to support him while the frusemide does its job. If he's able to tolerate an hour or two for the frusemide to do its job, then that would be the right choice. Nitrates and opiates used to be given routinely for patients with heart failure. Actually, they don't have really additional benefit. If you well, wanting to give something to get the fluid out, give more furosemide rather than nitrates, unless certain specific cases like ischemia. Um, and opiates are now not really used unless you're trying to make the patient more comfortable. You need to give more furosemide. So what dose of furosemide should we give our patient? Do you want to give a stat dose of 40 IV and then give 80 BD orally? Or do you want to give 80 IV and then 80 BD? Or do you want to give a furosemide infusion? Or are we going to go in with a big dose of IV and a big dose of an infusion? So we've got a vote for B. Any advances on B? So again, it's a difficult judgment, and what you really want to do is to see how the patient responds. This patient is really, really poorly. It doesn't matter how busy CDU is, you need to give something and then review. And it might be reasonable to do B or D here, and then review and say, actually, 240 is way too much. This is a diuretic naive patient, and you wouldn't expect him to need such a big dose of furosemide to diurese. I would give him 80 IV. You need to give a big dose because his hemodynamics are going to be in bad state because he's so overloaded. His heart's really struggling right now. You're going to need to give him a big dose to wake up his kidneys and get them peeing, as well as have the vasodilative effect, which happens very rapidly. It's the diuretic effect is then a bit more delayed. So giving him an 80 milligram dose stat would be absolutely right. Once his hemodynamics are a bit better, it might be that giving him 50 milligrams BDIV would be enough, or even giving him some oral furosemide. You need to see how he responds, but I would give him an 80 milligram bolus, and then we can think about the further management based on the response to that. How do you manage acute heart failure? Well, NICE have got some really quite nice guidelines for how you manage this. So they talk about the immediate treatments. And so we've talked about the way you manage pulmonary edema. Um, we can also think about cardiogenic shock when you might need to give inotropic agents. Cardiogenic shock is a really, really tough situation. And if it's in the setting of an infarct, sometimes we put in something called a balloon pump to try and support patients. But they, if they're this poorly, may need to be thinking about an ITU setting if they're a candidate for ITU. If they've got severe hypertension or ischemia, that's where we might think about a nitrate in addition to our furosemide. The NICE guidance do not routinely offer the nitrates or opiates, and they talk about monitoring the renal function, weight, and urine output closely. So these things we ought to be doing: the weight and urine output daily, the renal function at least every other day, and possibly daily, depending on how fast the patient is diuresing. Non-invasive ventilation, we've talked about, not routinely used, but it's critically important for some patients. There are other things like ultrafiltration, so you can use a version of dialysis to try and get the fluid out. And that can be considered, but it's not something I've used more than once or twice in years, so it's not a common thing. So that's the immediate treatment. You want to rule it in or out with a BNP, or now we use an NT-proBNP. This criteria from NICE I wouldn't really agree with. If it was a 20-year-old, then I'd want their NT-proBNP to be less than 300 or more than 300 perhaps. But for most of our customers, you're really expecting the BNP to be more than 2,000, but certainly more like 1,000. But it's recognizing that normal is less than 200. Between 200 and 2,000, we're not sure quite what to do with it. Over 2,000, we tend to think it's heart failure, and also that it can be high chronically in patients with chronic heart failure that are poorly. If they've got well managed and are symptomatically well with their heart failure, often it goes down even to normal, but it may be that it's chronically high. So look for a dynamic change, not by doing serial NT-proBNPs, but by looking at what it was 6 months ago and the patient was well, for example. And then our treatments, we think about doing the echocardiogram and managing based on the result. So what if they have a valve problem? What if they have left ventricular systolic dysfunction? Or if they don't have, we'll have something else, or maybe we need to pursue something else if their echo is normal. So if his pulmonary edema clears, what do you do next? You manage to diurese him. What are you going to do next? So imagine you're on one of the cardiology wards now. What are you going to do next now that his chest x-ray is nice and clear and the patient's feeling much better? I'll give you some options. So would you like to discharge the patient immediately? Would you like to start lots of drugs today at lowish doses? Get them on really good, we call these the 4 pillars. So really good drugs and get the patient home tomorrow. Or do you want to get the heart failure team to come and review the patient? Or do you want to get an echocardiogram and act on the result? Remember, you really want this patient to do well. So we have a vote for D. You want to perform an echocardiogram and act on the result. So does that mean you're going to sit on your hands for the next week while you wait for the department to do an echocardiogram? Does anybody vote for anything else? Do you want to just get in with the drugs that are going to make him live longer? Or would you like to let him go home and we can get the GP to follow this up? Yeah, you want to start on meds while waiting? Have I persuaded you that's a good idea? Well, until you know what the ejection fraction is, you're basically in a mess because why start an ACE inhibitor and spend ages up titrating it and then just stop it and have to wait 36 hours washout before you can start sacubitril valsartan? You don't really want to do that. You also need to be a bit wary of starting bisoprolol at 2.5 milligrams once a day. In heart failure, particularly somebody who's been in florid pulmonary edema like this, that is too big a dose because you might put him back into the heart failure. That's something to start with the patient stable, so it wouldn't be my first choice. And starting all of these things all at the same time is going to cause lots of problems. So B is certainly wrong, partly because the bisoprolol dose is too high, partly because we've tried to do too much too quickly. You might have the patient in for 4 or 5 days and consecutively start new medications. That would be the quickest you could do this. If you can discharge the patient before that, then that process should carry on after the patient's gone home, but the facilities need to be in place to do that. But you have to know the ejection fraction as your first answer in order to know what we should be doing. Maybe he's got critical aortic stenosis and we need to deal with that. Maybe it's heart failure with a preserved ejection fraction, and all these medications could just risk damaging his kidneys. A lot of people just ask the heart failure team to review the patient, and a lot of people just write follow up with the heart failure team on the discharge paperwork and just send the patient home. That is not something that we want to see. We certainly want the heart failure team to be involved because the heart failure team, they're a team of nurses, consultants, physios. We work closely with the GPs and community heart nurses. It's really, there's the pharmacists involved in the team. It's a very much a multidisciplinary approach. But our heart failure nurses can help with patient education in hospital. They can help go and chat to the patient and explain what's going on with them. So that can be a valuable tool for helping with the patient understand what's going on. And they are great at linking up to the community heart failure team on discharge. So they play a really critical role to help you manage these patients. But they don't replace consultant follow-up of patients. There are, as I said, 2,000 admissions with heart failure a year in UHL. We can't follow all the patients up, and we don't even try to. It's impossible. We need everybody to help. So your consultant looking after the patient needs to follow the patient up if it's appropriate to do so, but involve the heart failure team to help with education and get the community heart failure team involved to help carry on up titrating the medications and help keep them stable post-discharge. So they absolutely can help with that, but they can't replace the need for medical consultant to make a plan for the patient. And they absolutely don't replace you being careful in looking after the patient and making sure that, for example, their renal function is okay. You ought to have a renal function check a week after starting an ACE inhibitor. That's something that you'd need to ensure is being done for your patient. We have heart failure consultants at UHL. There are 3 full-time cardiologists that work as heart failure consultants. I'm one of them. There's Dr. Loke and Dr. Chan as well. We can review complex patients. These are not every patient with heart failure. These are the ones that you're struggling with. And we do certainly like following patients up. And we will, if you've got a particularly complex patient, we'd be glad to take on follow-up. But that's not heart failure team to follow up written on the discharge paperwork. We will just assume that means heart failure nurses. If you want one of us to see the patient, just as if I wanted one of your the other consultants to see one of my patients for follow-up, I wouldn't just think writing EP team to follow up patient on the notes would do the job. I would formally refer the patient and agree that they were going to follow the patient up before discharge. So bear in mind that you can't just say heart failure team to follow up and on the TTO and discharge. That just means the community nurses will see the patient. So in summary, it's important first off to clear fluid overload. And this gentleman, we talked about the 240 being too much. We would say that an appropriate dose of furosemide is the oral dose that they're already on plus 50%. So if they're on 80 BD, then you might think about giving 80 BD IV or plus 50%. That would be up to 240 milligrams. So that would be an appropriate initial dose. And someone who's diuretic naive, maybe 50 milligrams BD IV would be appropriate. Think about the need for respiratory support if they're tiring, if you don't have time to see the impact of giving the furosemide. And then they need to have daily use and ease to start off with, fluid balance and weight to assess their progress. They need an echocardiogram. That's not an option. They should not go home without an echocardiogram. This is a life-changing diagnosis. If they have severe LV impairment, you can make them live longer by giving them good treatment. It is totally unacceptable to let that patient go home and wait 3 months for the echocardiogram to happen as an outpatient, by which time they may well have ended up back in hospital again or done even worse than that. If they've got reduced ejection fraction, they need to be put onto prognostic medication, and you start that process in hospital, and that's continued in the community. And it's very important role for the community heart failure team and rehabilitation and getting them exercising as part of their care. Thank you very much for listening. I hope you found that helpful. So any questions at all?